Welcome to Centennial Oral Histories, a series featuring former and current leaders of Duke University and Duke Health, sharing memories of their time at Duke and their hopes for Duke's future. Enjoy this discussion with Dr. Victor Dzau, Chancellor Emeritus for Health Affairs and former President and CEO of Duke University Health System. Dr. Dzau currently serves as President of the National Academy of Medicine. He is interviewed by political science professor Peter Feaver.
Welcome to the Duke Centennial Project. My name is Peter Feaver, and I have the privilege of having a conversation with Dr. Victor Dzau, who is former Chancellor of the Duke Medical System, but also one of the leading medical innovators in the world. And so, welcome.
Thank you. I look forward to it.
Well, you came to Duke midway through your career. You had already established an impressive record of service and innovation. So talk a little bit about how you got into medicine even before you came to Duke.
So I would say that coming to Duke is one of the greatest things I've ever done. Great decision. But, I was born in China, Shanghai, right after the war. And that's my name's Victor. Then we were, because of civil war, Communist China, we were refugees from Shanghai to Hong Kong. Still remember the train ride crossing the border at night. We started, I would say, pretty modest and impoverished. That had a great influence on me wanting to be a doctor. So at age 18, I went to Montreal McGill to go to college and then medical school. After that, I did my training in Boston at the Harvard Systems, became a faculty member, went off to Stanford, and then went back to Harvard at both places as chair of medicine and chief of cardiology at Stanford. So when I got called about this job, I said, what an opportunity. It was an incredible opportunity for me to come to Duke.
Well, I'm going to ask you about that in a moment, but I want you to talk just a little bit more about your research and the contributions you made to cardiovascular surgery and treatment. I saw one place you were called the healer of hearts, which is a wonderful phrase. So talk a little bit about what you were able to accomplish in that phase of your career.
A little hyperbole, but still, I would say I started my career as a physician scientist, a doctor who does research. This is all under the model of William Osler. So I was really interested in finding ways to do research that can make a difference to patient care. Lucky enough, I was at Harvard with lots of great role models. So then I entered the career looking at cardiovascular disease. And at the time, hypertension was a really big issue and still is. Not too many good drugs. So it was at that time when a system called renin-angiotensin was discovered. And then I was in a lab trying to purify renin, make an antibody to block it, to show it's important for blood pressure reduction. And sure enough, I did, published in Science. So at the time, suddenly people say, okay, this is a great area to make drugs. So then the idea of one of the enzymes on the system, called ACE, became a target. And I was very lucky to be really involved with some of the earliest work in that area, including working at the Mass General to synthesize an inhibitor. Then, of course, pharma companies came up with oral drugs. I was the first to study in heart failure, put it into patients. I can tell you stories about those days with so little to give to patients, the drug really saved lives. So that's the history behind my work. Now, I've always done research. Everywhere I go, I still do research here at Duke. Even though I'm in DC, when I was chancellor, I was still running a research lab because it's really part of my passion.
Well, healer of hearts doesn't sound hyperbolic to me. Duke was known at the time as a center of excellence in heart treatment, cardiology in general. So was that what drew you to Duke? Talk about now what drew you to Duke.
A lot more than that. But just talking about Duke's reputation, surely when I was in training, you hear about the Duke cardiology, and particularly that Duke data, in which I think was Gene Stead who started it in 1980s or whatever. And of course, that was the basis of DCRI, you're going to interview Caleb later, right? So Duke had always been in the forefront of cardiology, but I came a lot more than that. Because I was at a time when I was chair of medicine at Harvard, and I can see that what I was doing was important. And maybe you talk to me about Paul Farmer later on, right? But when Duke called, I said, wow, it's got a medical school, a nursing school, a university, a hospital, a community. That at least gave me the chance to think about a much bigger issue of how to improve health community, how to get research going, how to improve education, rather than focus on a single department. So Duke, with his world-class reputation, was too good to turn down. So here I am.
Did you have much experience in the South? I mean, talk a little bit about what it must have felt like coming from the West Coast or the Northeast and then coming firmly in the South.
Almost none. I mean, I visited Duke before, right? And so South, I grew up in my life in Asia, then on the East Coast, West Coast, never in the South. Mm-hmm. So it was a really interesting adventure. I would say my wife was a little hesitant, but now she loves Durham now. She's the one who would say, we'll never leave, which is why I'm in D.C. now. I said, Ruth, I commute. You don't have to move. So we love the South.
What was the reputation of Duke when you came? So if I had been talking to you before you came, I said, describe Duke Medical, Duke University. What would be the way you would have described it before you came?
I would say excellence is the way to describe it in clinical care, great reputation in research and education, because Duke has a very unique curriculum in medical school. So it's a great reputation. And my predecessor, Ralph Snyderman, is one of the first to launch a health system, the idea of bringing hospitals together under one roof, and that's new. So for me, that's very exciting. But let's face it, if you did your homework, you also know that there were issues, and in which the trustee said we need a new chancellor to work along with the university better, and then the community says we need someone who can work with us, who can trust. So it was a challenge, but I give Ralph credit for his vision of creating it. Mm-hmm. My job was to make it work, and then elevate it to even higher heights, and then prepare for the future.
So talk a little bit about the challenges that you thought you would face as you were coming in. You said, okay, there's a new health system. I know I'm going to have to be doing what? What were the things you thought you would be focused on from day one?
Well, first, listen and create relationship and get trust. Mm-hmm. Key important. We all know this, like PDC and the health system, they don't trust each other, not in those days, right?
Explain what PDC is for
this is the private diagnostic clinic, mm-hmm. which is the faculty practice in a for-profit. That's not part of Duke. And so the struggle always is, I run the hospital, you run the practice, who's in charge here, right? And the trust issue is a big issue. Community. We took over 2 community hospitals, Durham Regional and Duke Raleigh, and the doctors in the community were really upset and didn't trust Duke. I still remember the meetings I went to where I had an earful about, you're coming in there to take over what we do and the whole bit. And, we had our detractors after Centennial, which was a major issue of patient safety issue. Mm-hmm. The community and the public didn't trust us too much about many issues. And then university relationship. So I had a fair amount of work to repair all those things. But I really want to hasten to point out, this is not a criticism of Ralph. This is where it is. It was, mm-hmm. right? He had to build it. As you build new things, people are always a little bit uncomfortable. And my job at the time was to make sure I make it work, to create an integrated system that everybody sees the same vision and work together in the same direction.
Well, talk a little bit about that. One of the things you worked on was a mission statement that would explain what Duke's health system was about. Can you talk a little bit about that?
Yeah, I think it's really important to take a step back and to say what we're all about. It's easy enough when you think about a medical center to say, we're about outstanding patient care, research, and education. That's the triple threat, if you will, right? The tripartite mission. Almost every center says that. We brought people together to say, what are we all about? Well, at the end of the day, it's about transforming medicine, right? Because research that we do and the clinical first, we can change the way we do medicine and make it better for everyone. Second is about improving people's health, not just caring for disease, but looking at the population health. And third, really importantly, if you see at Durham, but everywhere now, the inequities that we see in the country, right? So our statement says, transform medicine locally and globally, improve population health, and eliminate health disparities.
And when did you work on this in your tenure? Was this at the very outset?
At the very outset, what we decided to do is a strategic plan. And of course, it was not easy to bring everybody together. And then you start the strategic plan usually with the vision and the mission statement. But after you've done all the kind of listening to people, et cetera, you can see these are the pieces. And it makes a lot of sense because when we built the health system, when Ralph built it, it was supposed to be, well, we got enough hospitals, community, we have enough. Now it's our job to take it out to the community to serve the people we serve. And of course, also expand it to think about the inequities that we have in our society and importantly, globally. So we added a global mission to this.
Talk a little bit about the financial piece of it as well. That may be less well understood. Part of the reason for creating the health system was a financial one. So can you talk a little bit about that and the changes that were taking place at that time in the provision of healthcare?
Changes at the time and changes still happening, right? I think that this U.S. health system really needs to be markedly improved. Fragmentation, fee-for-service, all this stuff. But this is what, at that time, the idea is to say we're going to now have, shall we say, fewer beds, and we're going to reimburse differently. So the financial pressure was there for you to expand, to have more hospitals, even fewer beds, to look at how to distribute the beds differently, and like specialty versus, psychiatry, pediatrics, etc. It was very much a financial, but also I think for the right reason too. Because if you want to care for patients, you want the whole spectrum from acute care hospitals, complicated cases, to more routine cases of surgery, right? To ambulatory care, to long-term nursing homes. So an integrated system allows you to have all those things within one system. And the good news is that it's much less fragmented. That is to say, if you're a patient coming to Duke Health, you will have the ability to say, okay, I've got a plan that takes me from being in the hospital to going all the way home, along with rehab, etc. So that may be a financial drive, but there's also a right reason to do this. But we were losing money at big time when I first came. I still remember the first year I wrote off $200 million of loss in the Duke Raleigh Hospital, right? And but as you know, this is documented over the years. We did enormously well, at least under my watch. We actually rebuild, improve the efficiency, looking at how to build the referral system, looking at our specialty care, cancer, cardiovascular, and create a really, I think, successful system.
I don't know that this is well appreciated by folks who are far from Duke, but the health side of the Duke enterprise dwarfs the campus side and the other sides of Duke. That if you all are healthy financially, that has profound consequences for the rest of Duke, but vice versa. If you're struggling, that has implications for the rest of Duke.
Yeah, I'll say we're part of a university. And certainly I believe strongly the strength of being at Duke and Duke Health is part of a big university, not only because of the students, but because of all the other discipline. These days, we think about how do you improve health? It's no longer just medical sciences. It's social science, it's economics, it's policy. All that have to come together. So when you're in a university like Duke, you have access to all these great minds. And the idea of bringing them all together to really work on improving health.
Well, I want to push you now on some of the innovations, but right before I do, I want to say the other role of the Chancellor is crisis management. And shortly after you arrived, you faced such a crisis. I'm thinking now the hydraulic fluid issue. Do you want to talk just briefly what that was like and how you thought your way through it? And did you have second guesses about why did I come?
You know, that actually was a big lesson for me. I came, and before I came, there's a well-known case called Centennial. Centennial was a young girl who got lung transplant that had mismatch. And there was a famous case where news media were all over the place. So you say never again.
Right.
And yet in December, 6 months after I got here, I got a call from my COO to say, we got a problem. That we might have hydraulic fluid used to wash instruments. Now, what happened was that at one of the hospitals, they draining hydraulic fluid from the elevator, and they put it into a bin. The color of hydraulic fluid looked just like detergent. Now, you can imagine that, right? The bin, on the other hand, had a label that says detergent.
Oh, no.
And so, you know, it was an error, and the staff said, okay, there's a bin of detergent, let's move it to the loading dock to be picked up by the supply chain to use it again. And that's how it started the whole thing. So we had to figure out how many places did people use hydraulic fluid. We have to record over 3,000 cases. Now, the good news is that at the end, we did serious research to look at what if you had instruments wash hydraulic fluid? Is this now easily contaminated? Does it have chemicals? The good news is that, as you know, after hydraulic fluid, you still have to go through tremendous heat, autoclave, and the whole bit. So the answer is no. Then we mainly so there was no complication. We dealt with a public outcry. That's one thing. But I said to myself, wait a minute, twice bitten, right? You got to have a system that really is ready for patient safety and quality. That's when we really took this on seriously and created a full-time position for patient quality and safety, created a center of patient safety. I met with community leaders all the time, patients, and we report directly to a board of Duke Health in terms of the safety committee. So we changed the way we totally do things. And at the end, I can still remember that we would have annual meetings where 600 nurses, doctors would come together, talk about their work on patient safety and how serious we took it. And we took pride in looking at that's what we do. Crisis management, right? Learning from mistakes. So that was a big one for me.
Now, how do you emphasize patient safety without slipping into a zero defect mentality where you don't take the risks that you need to save patients' lives and move medicine forward?
Well, there are two things. One is that you can't blame individuals for errors. You know, the National Academy of Medicine, we used to call IOM, has this famous report to err is human. That is to say that mistakes happen. I make mistakes, others. But system has to be in place to prevent mistakes. And that's what we did. We created a system, right? Whereby if you go to a hospital, they check your bracelet, they check your date of birth, they check left side, right side. All that became a system by which you could prevent mistakes. So that's really important. So when you create a system, you become a lot more confident that, in fact, you have all the check and balances.
So you were a world-class researcher when you came. So surely part of your ambition was for Duke to take its own research to the next level. So talk a little bit about your vision for that and the steps you took to implement that vision.
Well, my feeling is a place can only progress with innovation. Without innovation, you get stagnant, right? You think about how do we do things better and differently every single day. And that's how you move a university health system to be better and better. So innovation is really, it has to be a DNA of what we do, right? Innovation is research. Innovation is also doing things differently. So when you think about innovation, a whole spectrum of new research, but different ways of doing business, different ways of managing, right? So there's organizational innovation, there's research innovation, all that stuff, education innovation. But so I have, well, I mean, this is part of my life. As I told you, I came from a background of, having to survive in different environments. And even, going from Asia to Montreal, that's a culture shock. Going from Montreal to Harvard, that's another culture shock. And so everywhere I feel I have to do things better and driven by how do I do things differently and better. So when it came to Duke, the system, as I said, was all put in place, and we have now people all working in the same direction, but you can't rest on your laurels. You can't say this is the way it's going to be forever, right? So therefore, we have to think about innovation. One of the things I thought about is what's the right model for an academic health center? We then call it a system, right? The model is to be able to move from discovery research, the great research that Bob Lefkowitz and others do, to be able to move it to human translation, the research that DCRI does, to be able to take that information and apply to patient care, our hospitals, but importantly now to move all the way down to the community society. All these take new ways of doing things, and that's what innovation is about.
And you changed some of the ways Duke operated to hit each one of those points. So talk a little bit about some of the institutes and things that you established on your watch.
So I actually created quite a few institutes. They're still alive and doing well. And first would be Global Health Institute. I'd like to come back to that. One is Duke Institute for Health Innovation. One is Duke Translational Medicine Institute. DCRI we already have, right? And then we also did the medical school in Singapore. And then, of course, the Duke Cancer Institute. Let me start with the last. Because Duke Cancer Institute is an example, to me, of what needs to be done to deliver best care. Well, we all know about the famous history of Duke Cancer Center, being one of the first comprehensive cancer centers in NCI designated. But it was really a research center. And the work that was done by the clinicians, and we know many of them, was great. Surgery is another segment. They do surgical oncology, they do radiation oncology, so a patient had to navigate themselves between different departments. You remember those days, right? Where you're you're at Duke West, Duke South, whatever, right? So it became very obvious. If you think about the patient, you want to put everything in the same place. You want the doctors to be in the same place, the nurses in the same place. You want research to be close by so that the kind of research you do is informed by patients and vice versa, changing care. It was quite a task because the Department of Surgery, Department of Medicine, Department of Radiology said, no, we're doing fine. So I have to find ways to kind of carrot and stick to create a true integrated cancer institute, to build a building, to recruit a director, to make it like a brand new launch towards a cancer, that it should be. Closer to what you can see in Sloan Kettering and MD Anderson, right? So that's an example.
And that was a bold move for you, someone from cardiology, doing that in cancer, not in cardiology. Why did you pick cancer as the place?
Well, because I feel that in cancer, first of all, patient needs, right? Patient navigating, imagine cancer having to navigate all these things. Secondly is the opportunity to bring together all these pieces to make it even better. Cancer was a perfect one. If you look where we are today, right? I mean, you think back on the Tisch Brain Cancer Center, the ability to operate on brain tumor. If you look at the research that's been done, all those things can be integrated for the patient. Immunotherapy now, CAR T cell. So that was the right thing to do. In cardiology, we did it more functionally than structurally. In other words, we did have a service line director, surgery and medicine cardiology were working closely together. So I think I didn't see I need to do it as much as I need to do in cancer.
Talk a little bit about the Innovation Center, because that brings in the business side of things as well.
Yeah, very much, because again, the whole idea is that if you're going to be better and better, you got to innovate. And so we learn, especially like after patient safety, how frontline people are thinking about how to do things differently. You want to listen to them. They can say, you know what, I see something like this, something we can do differently. And there are lots of clinicians and researchers who can see how our current way can be improved. So we want to create a place for them to say, I've got a good idea, and if the good idea is supported and realized, then we can improve patient care and research. So the idea of DHI, we call it. But the question really is, how do you make sure that the right innovations are there? So we created this institute whereby we have resources, we give out grants, they have to be competitive, look at is a good idea, and to be selected. They have to be selected aligned with the executive and directions, meaning you have to have an owner. If that is selected, somebody who's an executive says, I own it, I'm going to work with them to see it through, not just you're going to be out there doing things. And then we had people who are investors, actually along with looking at, okay, those are great ideas, where would we like to invest in it? So I think what's happened at DHI is the AI is the big issue. They've done so much in AI. They can use AI to predict sepsis, AI to look at people who are likely to get renal failure, so you can early intervention, AI to manage patient care. So that, among many other things, I would say the timing was great because now we're really taking new technology, look at how to do things differently and better.
Mm-hmm. Let's talk now about globalization. You came to Duke originally from Shanghai, so you saw the world as much bigger than the South, and you brought that vision to Duke. So talk a little bit about the steps you took.
Yeah, I think that if I were to look back, I'll say, for me, the areas that I would emphasize would be leadership, innovation, and globalization and equity, right? Globalization is really important, but I would say, given my background, you're right. But it wasn't until I met Paul Farmer, who's a member of my department at Harvard, and Jim Kim, the two of them. And Paul, as you know, is a Duke graduate, right? So Paul, when he was here, suddenly discovered anthropology and looked at the migrant workers in Haiti and became really passionate about this. Went to Harvard Medical School and took an anthropology kind of emphasis, medical anthropology, with a good friend, Jim Kim, who then became Dartmouth president, World Bank. The two of them began to do these things. So when and they founded an NGO called Partners in Health. When I first arrived at Harvard at Brigham Women's Hospital, the chairman of the board then, John MacArthur, who was the dean at Harvard Medical School, told me, you ought to meet these two guys. They're really interesting. So I met them, and it ignited the stuff in me for all this while about global health, right? And so what I did is I helped them create a home, a division called Global Health Equity, because they were doing part-time in Haiti, rest time they have to do hospitals, ID, And there are many young people taking the elective time, but when they're all done, they say, I can't do this any further. There's no pathway. So I created this for them. So there's career pathway, research, etc. And today, that division had like 60 faculty members doing really well, right? So when I first came to Duke, that was the year the book Mountains After Mountains was being the must-read for freshmen. Paul came to campus. We had in Page Auditorium, and it was packed with students, and he was ready to sign books. So I went to Broadhead. I remember we were at a retreat with Peter Lang. I said, we need to think about global health. And sure enough, at the end, we got a committee together with Bart Haynes and others to look at what's in Duke. There's a lot of pockets. We decided to create an institute. And Broadhead and I both put down money to create $35 million to recruit a new director, where Peter and I, Lang and I, both oversee. And that was the beginning. But it was actually capitalizing on the passion already there. The work's already there. What we did, just like I talked about health system, is that we bring people together. And it's amazing. When you bring people together, the power is amazing. And people are doing, wow, the university health system really cares about this. Students say, we want to do things like this. And of course, Mike Merson, who recruited as first director, reached out to undergraduate. It was a great success. But I think what's exciting are the following. One is we're doing what's right for low-resource country, like Paul Farmer would have like us to. We're doing great research. But the young people, that exposure, understanding the world is not all equal, there's a lot of work to be done, we can do good, I think really is inspiring. So that's the Global Health Institute. Almost the same time, as you know, the Singaporeans said we need a new medical school. Yes. And we need a research school of medicine versus a clinical to really look at how we can take advantage of the fact that we're investing in this biomedical enterprise called Biopolis, year 2000. And we need a school, and they decided to select Duke. So I was very lucky to a chancellor to want to make it happen. And, we had Sandy Williams, Ranga, Krishnan, I mean, great people. We took it seriously. And I would say, without, being immodest, it's probably the most successful international medical school ever. People have tried it, Hopkins and others, and have failed. Ours is going strong. And I'm in Singapore a lot, and they continue to sing our praise, how wonderful this is. And it's good for Duke. As you know, they explore innovation, new way of education, flipped classroom. They came back to influence us as well, right? So this was a great thing.
Wonderful. You, at the same time that you had this international focus, you also had a very local focus here in Durham. So let's talk about that a bit. And there, of course, is health inequities, I should say, right in our own hometown. So talk about how you were able to bring the global to the local and affect at the local level.
Well, among the many important lessons learned, I would put that among the top. We talk about globalization, innovation, but I would say community became something for me that's really, really serious, and I learned a lot. Why? Number one, we serve 90% of the population in Durham. So we can't be an ivory tower just to say, when you're sick, we can take care of your surgery. If you really want to take care of people, you got to reach out to community. Secondly, our employees. Time I was there, we had 25,000 employees under Duke Health. There's probably a lot more now. So you can imagine their families, they work for us. So suddenly I realized my responsibility is more than a hospital, more than a medical school, more than a nursing school. It's about the people we serve. And I mean this sincerely. I'm not kind of saying it because it's the right thing to say. So at the time when I came here, there was a lot of lack of trust. They had to have us run the Durham Regional because they're losing money left and right. So it was a lease and a management contract that we had, right? And so there was always the tension. And I would like have a shout out for Marianne Black, who was just wonderful. She was my AVP for community affairs. She taught me a lot. We went to communities, met with people, met with the mayor, and really understand that if we're going to do well, the community has to trust us and we need to serve them. That started a journey of creating community health centers, clinics, and I'm very proud of City Medicine Academy, right?
Talk about that. What is that?
Yeah, so we own the land on the, well, we in long-term lease the land on Durham Regional. In our negotiation for the next phase, I said, let me give you 1 acre land to build that school, because the mayor already had the idea and a few others to build something. You know, we know in the City of Medicine, right, Durham. So wanted to leverage to teach our young people the opportunity about a health profession. You know, it could be radiology technician, could be pathology, could be medicine, you name it, right? So they already have the nidus of this. All they need is our know-how and the resources to make it happen. So I said, okay, build it in our hospital so that your graduates can actually have access to it. We'll bring in our faculty, and in fact, to the credit of people like Tolman and others, we gave a lot of equipments and stuff that we don't need. They took a bond, and they built a building there. And then they created the school where the emphasis of curriculum is part of it. They still get the regular curriculum is health professions. It's a lottery school. But you know, the lottery school, everybody applies to it. They have 600 students and graduation rate, last time was checked, was 100%, right? Very proud of it. It's a kind of a, shall we say, partnership with the community, right? And I, you know, so I'm very proud of the fact that when I stepped down, the mayor gave me a key to the city, right? So I feel that that's one thing, is serving people. That links with the global health issue as well, serving people. That's why our mission statement was so right. Eliminate health disparities and improving population health.
I've met many people in Durham who say, well, I don't root for Duke in sports, but I root for Duke medicine. That
is
right?
that
Nice. They're alive, or their loved one is alive because of the care they've gotten. So the health system is having an enormous impact in Durham. How has Durham changed the health system?
Oh, in a big way. As I said, I think let me put it this way. Our doctors and nurses are the best. They focus on taking care of that patient that come to them, right? So if you're a cardiac surgeon, you focus on that. And you hear that from Gene Washington too, that what's changed is that we understand we also serve the entire population. We serve the entire community. And therefore the issues are not only, do you have an illness? It's where do you live, where do you work, what food do you eat? We call social determinants of health, right? Those things matter because the data show that healthcare only accounts for 10% of health outcomes. The rest is social, behavioral, all that stuff, prevention. And if we don't pay attention to this, all we're doing is providing sick care. We want to provide well care, prevention. So understanding these issues, like for example, I remember an old lady, African-American lady with asthma. Until you go and visit her at home, walk up the 4 flights, dust-filled home, you realize why she's got asthma. And, you know, people who have environmental justice issues, you name it. Food security, right? Actually, do you remember Mary Lynn Miranda? She's now president of one of the universities. She did geospatial mapping. We used to map, because we are taking care of all the patients in Durham, we have the information on them. We used to map where the disease clusters are. We map where the barber shop is, where the, good food versus, grocery stores, all that stuff. And you can see the diabetes, all that stuff and we can begin to design the care. That, I believe, is really the lesson we learn in terms of community. Because at the end of the day, we're citizens of a community. And they are what make up what we are, right? They are workers, they are leaders, and the whole bit. We need to work alongside with them.
It's my understanding that interest in Durham is a family business now for the Dzau family. So can you talk briefly about what your wife is doing in the space?
My wife has done so much. She was one time the president of Center for Child and Family Health. If you go down towards the city, there's a big building called Duke Center for, I think it's called Child and Family Health. And she was the chair of the board, not president. And they relook at these children who come from difficult families, who have traumatic background, and they did great stuff. She was on many boards, but her passion right now is Durham history. Mm-hmm. She was one of the people involved with the founding of Durham History of Durham Museum. She's still on the board. She was chair at one point, and believe me, she's working so hard from a, shall we say, a small footprint. They have aspiration because she's so proud of Durham that the history of Durham needs to be told. And if you tell about the history of Durham, you obviously care and proud of the organization, of the community, and try to make a difference.
So let me go back to your emphasis on research. How did the research profile of Duke Medicine change over the 10 years of your tenure?
Well, I mean, I can't take credit for this, but boy, certainly during my time, we got the first Nobel laureate, right? Bob Lefkowitz, and then Paul Modrich, right? We had cochlear implant, Blake Wilson, right? We've done lots of really groundbreaking stuff that finally we got the recognition for this discovery type research. Bart Haynes' work on HIV, right? Great stuff. But DCI played a really important role because it's not just sitting in the lab doing this stuff. It's trying to say, how can we actually make a difference in clinical care? Mm-hmm. And DCI became the largest academic research organizations to Caleb's credit and many of his successors. And our reputation clearly is Duke Health is a medical center of innovation from basic research all the way to clinical research.
Now, that kind of emphasis on research puts pressure on the individual researchers. And
yes.
There's an ethical pressure that they experience as they're struggling to get grants, produce results. And that leads to my question about one of the other hard chapters in your tenure, which was the potty case. The potty case. So talk a little bit about that.
If you ask me what are the two major setbacks, lessons learned at Duke while I was there for 10 years, those were the two. So we were at a time where genomics was getting to be hot. And people begin to be able to measure gene expression, right? And also genes, now you can sequence, but then, still early. But we're at a time when people say, it makes sense to have precision medicine because if you know your genes and your gene expression of a cancer, you can predict what the problem is. You can tailor treatment for those. That concept is absolutely correct and still is. If you look at what's happening in cancer area, there are a lot of very targeted cancer therapy now, right? Amazing. Concept is right. The science is almost there, so the pioneers are moving this direction. And we believe it too. Duke was pioneering in this area, right? I mean, we had Bob Nevins, we have, lots of people, Hunt Willett, people like that. So we had a young investigator by the name Potty, and he says, hey, I got something. Look what I'm doing. And, in many ways, we could have learned better to say, let's look carefully what you're saying. But because the momentum was there and people believed this could happen, and that Duke has the ability to do it, I think a lot of people believe in him, right? Senior scientists and many others, and of course in the public. And therefore he got elevated to be a lot more visible. And that was our mistake, right? We learned, of course, that you got to be very, very cautious. And so we actually went back and looked at data provenance. Have you seen the original data? How good is it? Data governance, who's overseeing this stuff, right? And of course, integrity, research integrity, all that stuff. And so we learned a lot. And of course, that changed us tremendously in looking at the way we organize research. So you're right. I mean, what you're saying is a spectrum. When you have innovation, great ideas, you got to do the right thing. So along with it has to be scientific integrity, right? Oversight and excellence. That's the whole spectrum. I still say Duke does it all. Few blemishes. Those blemishes have taught us big lessons.
Mm-hmm. You've mentioned a number of names over the course of our conversation. Are there any other names that stand out either from earlier before you arrived or during your time that you say they really made a mark on Duke and helped move Duke forward?
Davison, the founding dean, Bill Elliott. Bill was really an amazing guy, and coming, I believe, from Egypt. But we were not known much of an entity. Bill make the reputation, at least in U.S., right? I already mentioned Ralph, right? But I think these were the giants we built our programs on. And of course, we need to do even more and better. So absolutely. I would also say that people like Sandy Williams, Ron Krishna, they're really great people who did a lot for the organization. High quality excellence, integrity, innovation. I can name a lot of people like Bob Lefkowitz. I already named them anyway, right? Yeah.
Now, when you stepped down from Chancellor, you did not retire from the medical profession. You moved on and you have an important post now. Talk briefly about what your current post is.
Yeah, so I'm not sure in my vocabulary there's such a thing as an R word. Maybe that's because my whole life I'm driven to try to do better and to be making a difference. So when I was at the tail end of my chancellorship, 10 years, Brian and I had many conversations. What I want to do in the future, as you remember, Dick extended his for a few years. Mm-hmm. We considered this as loving my job. Also, we consider it's time to move on. And would I stay, therefore, to run DHI and take some of those institutes that I put together to take the next level? Then I got the Institute of Medicine knocking my door, National Academies. I would say what attracted me there is the following. I've done research, patient care. I've done departments and medical centers so they become local, regional. I think the National Academy is a national and international. The platform is such where I think I can make a difference based on my experience that I have, bringing my research, my education, clinical experience, and the policy in the community. So it fits me nicely because what we do at the Academy is basically looking at really what are the issues we need to deal with for this country and globally. How do you go forward? We were founded, the founding organizations, National Academy of Science, which spun out to be 3 academies. 1863. Abraham Lincoln Congress found us as independent. We're not part of the government, but to advise them during Civil War and science, and then now, of course, all this issue. So my feeling is I've got a chance to really do more for this country. And I mean this sincerely. This country gave me a lot. I'm an immigrant. I became an immigrant in 1990s, 20 years, a little bit less than 20 years after I came to this country, right? And so to me, having that opportunity, and then also in global stage is important. So we do great things. And I see a lot of Dukies in DC to work together, like Mark McClellan, Bob Caleb. We're making a difference.
Well, apply your new perspective back to Duke. As you look at Duke, where does Duke need to go in the future to maintain a positive trajectory?
So here's some prediction. If you look at last century, right, think about all the things that's happened in the last century, or even 15 years, the iPhone, or even, 50 years, the Genome Project, right? And the drugs that we have, other things. So to me, health and medicine is going such gangbusters. The innovation, the emerging technology, AI, genome editing can cure disease. I think we're going to see phenomenal changes in health in the next decade, 2 decades. So Chan Zuckerberg created an initiative, right, on biomedical research.
Right.
2018, and they asked the question when they launched the initiative, by the end of the century, will we be able to cure, treat, or manage all diseases? What's your answer? That's 80 years from now, 75 years.
It's hard to imagine. I mean, it feels like that's part of the human condition. And you're saying that it's within reach to change that.
I think if you look at 80 years, I started practicing medicine in the 1970s, right? And I'm a cardiologist. What didn't we have? We're just beginning to have coronary care unit. Defibrillator, pacemaker just started. We didn't have drugs. We didn't have angioplasty. I treat heart failure. We had 2 drugs, digitalis and diuretics. Digitalis doesn't work. Now we have so much. We have obesity drug. I think it's totally plausible. In the next 75 years, we've got everything that we need. So that's my question. Then what? It's that a lot of people don't have access to it, right? Yes, you can. You can have gene therapy, $4 million a shot, but can the average individual have it, right? You can have AI, right? And how are you going to oversee some of those usage and regulation? So I think we're entering a very different era from where everything that we did is possible to things that we do but not available to everyone. Let me make my case. American life expectancy is dropping, it's not flattening, right? While we have this great increased life expectancy with all the drugs we have, we begin to see this. And if you go to Durham and just go between Hope Valley and down in the low income section, you could see 20 years difference in life expectancy. It's called equity, access, affordability. I think for Duke to continue to lead, they have to stay ahead of, just because we can invent, we can treat better, we got to really get into the social issues. Because that's what we're about, human beings, right? Improving their well-being, their health. And I think the next decade or more, the ability to bring in social policies, social science, economics, things like that, to make a much better community, I think is where we need to go.
If that initiative is successful sooner, you and I will be able to gather 25 years from now and have another follow-up conversation. At that time, looking backwards, what will you want to say is true about Duke? So 25 years from now, looking backwards, what do you want Duke to have accomplished?
I'll say the following. Number one, as a university, we continue to be the knowledge capital of the world, producing the best people and leading in society in so many different ways. As a health system, we continue to be, as we aspire to be, that system that improves care, bringing the very best, but most importantly, we became really the place where, we think about everybody that can benefit from us. So people no longer say, that's that elite, University Harvard of the South, to that's the place where everybody would like to be because it's so wonderful in serving everyone. I don't mean to be, Pollyannish, but I sincerely mean it. I spend a lot of these days thinking about in what I do and how to improve the social issues, right? The systemic issues that we face with. Because I think that's in the way of achieving wellness. It's not technology, it's not innovation. There's plenty of people out there, especially it's a market-driven. I want it to be more mission-driven approach to the area.
Well, Duke has a chance of achieving that vision in part because of your hard work and your contribution to Duke. And for that, I thank you, and I thank you for this conversation.
Thank you. I really enjoyed it.
Me too.